All right, welcome back to the training room. Today, we're putting on our compliance trainer hats and exploring the source material for part 2 of our explainer series. We're diving deep into credentialing fundamentals, along with those incredibly strict NCQA and URAC standards that govern them. Look, if you work in pre-revenue cycle management, or pre-RCM, you already know that the stakes literally couldn't be higher. I mean, one missed document, one expired license, and your entire revenue cycle can grind to a sudden, very painful halt. So today, we're going to break down the rule books, map out the audit cycles, and figure out exactly how to bulletproof your processes.
Okay, let's quickly run through what we're covering today. First, the core pillars of credentialing. Second, the NCQA gold standard. Third, URAC and telehealth standards. And finally, best practices and automation.
Section 1. Core pillars of credentialing. Building the foundation. Let's get right into it.
Before we get into the heavy regulatory rulebooks, we really have to establish our baseline. So what exactly is provider credentialing? Well, simply put, it's the systematic process of verifying and validating a healthcare provider's qualifications, education, training, licensure, work history, board certification, and malpractice history. It ensures they are qualified, licensed, compliant, and most importantly, safe to treat patients. You have to think of this as your absolute first line of defense in pre-RCM. It's that critical step that has to happen before a single claim is ever submitted to a payer.
Everything your team does actually rests on 4 core pillars. Pillar number 1 is patient safety. This ensures that patients are treated only by certified, legally authorized professionals. Pillar 2 is regulatory compliance, which is absolutely mandatory if you want to participate in government networks like Medicare and Medicaid or commercial insurance networks. Then there's Pillar 3, timely reimbursement. This is where the financial rubber meets the road, right? Providers literally must be credentialed and enrolled with payers to actually receive payments. And finally, risk mitigation, which reduces your organization's liability from fraud, unlicensed practice, or poor quality care. If any one of these pillars cracks under the pressure of an audit, the whole system just falls apart.
Moving right along to Section 2, NCQA, the gold standard, the strict rule book. The NCQA, or the National Committee for Quality Assurance, is the benchmark. When an auditor walks through your door, which, let's be honest, usually strikes fear into the hearts of an entire RCM team, the NCQA guidelines are exactly the standard they are holding your files against. Whether you're a health plan, a credentials verification organization, or a traditional hospital, this is the absolute rulebook you have to live by.
What's really fascinating here is the strict 36-month cycle. You must credential every single provider every 3 years, without fail. Think of it as a continuous clock. In month 1, you have your heavy lifting, initial credentialing and primary source verification. Then, from months 2 through 35, you aren't just sitting back. No way! You are actively responsible for ongoing sanction monitoring and timely notification of any adverse events. Finally, at month 36, the cycle completely resets with mandatory recredentialing and a comprehensive file audit. You literally have to touch every single provider file and prove you've been watching them the whole time. So what exactly needs to go into that file to actually survive an audit? Well, the mandatory elements include a valid state license, DEA certification, board certification status, a full malpractice claims history, and at least a 5-year work history. You also need rock-solid proof of primary source verification, meaning you didn't just take the provider's word for it, you went directly to the issuing source to verify it. Plus, you need the actual notes from your credentialing committee review. If you're still relying on manual, paper-based folders to track all of this, auditors will find your gaps for sure, and it won't be pretty.
All right, Section 3, URAC and telehealth standards, expanding the scope. The healthcare landscape has fundamentally shifted lately, which brings us to another vital accreditation body you need to master. Let's compare NCQA and URAC. That's the Utilization Review Accreditation Commission. While NCQA is your historical baseline for traditional hospitals and health plans with a strictly clinical focus, URAC steps in to regulate a much broader, often remote first world. URAC accredits telehealth providers, pharmacy benefit managers, and utilization review organizations. Unlike NCQA, its scope goes way beyond just clinical credentialing to include non-clinical standards. It adds very specific telemedicine-focused credentialing checks. This is absolutely critical if you're dealing with specialty networks or startup health organizations operating across state lines.
Which brings us to Section 4, Best Practices and Automation, the Toolkit.
Knowing these complex NCQA and URAC rules is really only half the battle. Managing them at scale without drowning in paperwork is the real challenge, and this brings us to a massive industry hurdle. How do we actually beat the manual credentialing trap? When you rely on paper-based forms, faxes, and emails, you suffer from slower turnaround times and inevitable data loss. With delayed provider activations, non-standard processes varying across states, and payer rejections breathing down your neck, manual paperwork just isn't an option anymore. It's actively hurting your bottom line.
But here's the good news. We can map these high-risk manual challenges directly to automated tech solutions. If your challenge is endless paperwork and manual submission, the solution is adopting modern credentialing software like Payor Health or Silversheet. Struggling with primary source verification tracking errors? Just implement checklist automation directly into your LMS or standard operating procedures. Missing strict deadlines and SLA breaches? You need turnaround time dashboards and automated reminder systems. And for the huge headache of payer form variability, enterprise platforms like VerityStream, specifically their CredentialStream tool, can manage payer document libraries with pre-filled automated templates. It's a total game changer.
By leveraging these specific tools, you effectively remove human error from the equation. Let's look at an advanced pre-RCM tech stack. With a CAQH ProView API integration, you can automatically upload and sync provider credentialing data directly with payers. Tools like Payor Health and Silversheet act as your cloud-based CVO, sending you automated alerts long before a license or reattestation expires. We're even seeing the rise of RPA, robotic process automation, where bots actually do the tedious work of filling out payer enrollment forms. And NLP, natural language processing, is being used to automatically extract data and verify documents, like CVs and W-9s.
As we wrap up this explainer, I want to leave you with a critical question to take back to your teams. Look closely at your internal processes right now. Is your current technology stack truly ready to survive your next strict 36-month NCQA or URAC audit cycle? Because the reality is, compliance isn't just a dusty binder on a shelf anymore. It's an active, ongoing system. If your team isn't equipped with the right automated toolkit, you are leaving your organization exposed to massive regulatory risk and revenue loss. So, take a hard look at your master tracker, run those QA audits, and make sure your foundation is rock solid. Class dismissed, and keep building those best practices.